So that's why there was a high amount of training from these countries. But now there's not really that many doctors and stuff because a lot of them left. Everyone leaves Bosnia. That's kind of the big
consider it
takeaway.
like a failed state?
I would consider it a very corrupt state. I think if you ask anybody there, when is it going to get better, they'll say never. Or at least that's kind of the understanding that I've gotten both from my family in America and in Bosnia. It's just never, it's never going to get better.
This is an area of the world where there has been a clash of religion and culture for hundreds of years. The intersection of Catholic Christianity, Orthodox Russian Christianity, and Islam.
But in Yugoslavia, it was very well known that, everyone lived together. Like, I have aunts and uncles that are Muslim. I have cousins that are Orthodox. My family is rare, actually, in that both my parents are Croatian.
So,
I don't even know if I can think of anyone else in my family that both of their parents are the same ethnicity.
so interestingly enough, under communist rule,
That's what I'm saying, yeah.
Tito, as we've heard, was the leader. It was communism light in many ways. It wasn't as authoritarian as Russia or China. Yet, it was authoritarian enough that it forced all of these ethnic groups to come together into one country called Yugoslavia and get along. And as soon as the Soviet Union collapses and and Tito's dead, everyone goes back 2 generations to all the hatred and issues. And here she's Croatian living in Bosnia. And that's one of the reasons that she got stuck in the conflict. She was the wrong ethnic group, wrong religious group, in the wrong place.
Yeah, that was definitely it was the Croatian minority that the Serbians were attacking in Bosnia.
So we got to move on, okay? So let me make 2 key points that Irma has very clearly stated, but let me just summarize them. Number 1, you cannot have a healthcare system during a war. It just doesn't happen, okay? It doesn't matter where you are. Okay, now for the United States, we bring our wars to other people. So we do fine in the United States as long as the war is someplace else, right? But if you have a war in the area, you can't have a healthcare system. Secondly, you can't operate a health system when there's corruption, and we've talked about that a bunch of times. And corruption and war tend to go hand in hand. Okay, so there's just chaos. Okay.
There was one more. Did you have a question?
Oh, I was actually going to chime in about Albania, also because it was a Balkan country. And actually how it was the epitome of coexistence insofar as the religions were concerned. So, I mean, I think there are Balkan countries that are able to really nicely coexist.
Right.
I mean, in Albania, they were...
It's known as like the world's most tolerant country.
Yeah, atheist. And religion was totally abolished under communism. So actually, when they were able to start practicing again, most people don't. But even so, they're so accepting. I wonder if that's the case now in Bosnia.
It's kind of reverting back to that, but yeah, there's definitely Balkan age. So when I lived in Bulgaria, and I was in a Turkish town in Bulgaria, on the border of Turkey and Kyrgyzstan. And it was a very tolerant area, and the Bulgarian politicians, you'd see them being like, "Oh, there's so many issues in Kyrgyzstan, like the Roma population, the Turkish population, and the Bulgarians, like and the Pomok population. They're all like," and there was absolutely no tension, and everyone was like, "I just speak like 5 languages because I'm Turkish and Bulgarian, and I speak English and German, and yeah, no, there's definitely great places in the Balkans, and Bosnia is a sad place, but."
Okay, thank you.
You're welcome.
Now,
Hope everyone's do something happy after this.
well, I think, I don't know, Saudi happy. If you're Saudi and a member of the royal family, it's certainly happy. Okay, this is what we're going to do. We're going to set up and we're going to get started with Saudi next. Oh, with you with Ilya next. Okay, excuse me. If you need to run to the bathroom, do it while we're getting set up, okay? If not, we're going to keep going. We're not going to do Schusteristan today, but we are going to do 2 more presentations. If you've got to go to leave for the afternoon leave, okay? But we'll keep going so that we can get done at least with our presentations, okay? And Mayan, if you want to take your quiz during one of the presentations, I'll give it to you, run out and do it, okay? All right?
That's what I wanted.
Gilly, you ready? Yeah, you can. So go, goodbye.
Julia, what country are you doing?
Yeah.
German.
Okay. Oh, that's just like my time when I go do it. No, like, oh, yeah, it is the same. Okay, I think it's
There is some video on YouTube. Summarize.
Hopefully, it will be okay. So this is probably you.
right? See you later, Kingdom.
Later.
Where are you going?
It's memory.
You better be going to write your bio.
Yes, Germany, yes.
Germany, right? And
Kingdom, I swear to God.
here you can find a link to YouTube.
Isabella.
Let's bring this.
Very bio.
And you want the other ones brought in as well?
And I was like, do you want to Skype
Yeah.
in? I was like,
Yeah,
nobody
this one.
wants.
Healthcare
You have a
Germany.
link to YouTube. Summarize everything I'm going
I was
to
just
speak
with
about.
Claudio as
You want this one too, or no?
Something.
Here is my
Summed up.
Albanian.
Some
Look at him.
This is what Albanian looks
For
like.
our econ presentation, that would have been
For the other 5 times I
Yeah,
presented
like,
on
Skype her
Albanian.
aunt. Ask her questions. She's really sick. I was like, I'm not sending my aunt to ask her sad questions about healthcare. That's not what's going to happen.
yeah, go enjoy.
I took mine.
If I can't solve it?
There's multiple
Here's this. And I think you're ready.
You don't
Okay.
No.
No, you're ready to worry.
Yes.
And then.
Thank you. You can try a pencil?
Yeah.
Or
It's
do you have an eraser? I'm usually not so confident. So try. Oh, yeah. Nice. Yeah. I don't know. Yes, great. Cross it out. Oh, yeah. Thank you, Isabella. What else? That's it. Your love and support. No problem.
Take your time.
It's like behind, you know where we call the train? Yeah, it's like two blocks.
Should we start?
Yes,
Yeah.
let's start.
So I'm going to represent you Germany system, German health care system. And first of all, I would like to show you a video on YouTube that summarize almost everything I'm going to speak about. So. I think it's wrong. Something wrong with this.
Yeah. Huh?
This is the whole video.
It doesn't work.
Okay.
Let me try to put it on this volume. It's here.
Yeah, that it was working, right?
This is the thing that breathes.
Okay, turn up the volume there.
In Germany, you could choose not to buy insurance. but that's no longer the case. Insurance is sold only by nonprofit private companies. There are more than 130 of them. The last international healthcare system we covered in
Yeah.
Singapore had a great response. This week we head back to Europe. Specifically, we're going to Germany. Their universal healthcare system is based on the principles of Bismarck, which say that the state should provide only for those unable to provide for themselves. It's a private insurance system, and it's the topic of this week's healthcare trio.
I'll do it.
Everyone has to get it. Before 2009, some of the richest people in Germany could choose not to buy insurance, but that's no longer the case. Insurance is sold only by nonprofit private companies. There are more than 130 of them, and they're also known as sickness funds. There's statutory health insurance, or SHI, or voluntary private health insurance, or PHI. PHI covers some of the benefits that SHI doesn't, but most are minor. It also gets you access to some better amenities and covers some co-pays for other services. 86% of Germans are covered by SHI and 11% by PHI. As with other universal systems, the insurance is pretty comprehensive. Coverage includes preventive services, hospitalizations, outpatient visits, prescription drugs, mental health, dental care, eye care, rehab, hospice care, physical therapy, even sick leave is covered. Long-term care is covered by a different insurance, but that's mandatory too. There are limits to this though, and some people buy supplemental private long-term care insurance. Any employed citizens and pensioners who make less than 52,200 euros a year and their dependents are covered by SHI. Anyone who makes more than that, or who is self-employed, can choose to get the SHI or buy PHI. About 3/4 of people choose the SHI now. There used to be no co-pays for SHI, but some were added in 2004. They were about 10 euros for a doctor's visit. But in 2013, most of those were removed again. There are still co-pays, 5 to 10 euros for prescriptions, but lots of those are still free, 10 euros a day for hospitalizations, and 5 to 10 euros for medical aids. Deductibles can vary by plan. There's no cost sharing at all for kids, and a cap on out-of-pocket payments at 2% of household income. That number is 1% if you have a chronic illness. Out-of-pocket spending accounts for just over 13% of all healthcare spending in Germany, making it slightly less than Canada, comparable to the US, but much more than France. About 72% of healthcare spending is public spending, and just over 57% comes from SHI. Employees or pensioners pay an 8.2% tax on their wages up to 47,250 euros. Wages above that are exempt from the tax. Employers contribute an additional 7.3% tax. The contributions are all put together and then spread out amongst the nonprofit SHI fund. If a fund runs low on money, it can charge the members a bit extra. In 2011, 13 of the 156 funds did so, to the tune of about 100 to 180 euros a year. PHIs are considered private health spending. There were 42 of them in 2011. Slightly more than half of them are for-profit. The other slightly less than half are non-profit. The premiums are risk-based on entry into the program, meaning that older and sicker people pay more. Employers make contributions to PHI as they do for SHI, but the employee contribution is higher. PHI is still tightly regulated by the government to protect consumers, though. Laws also encourage competition between the funds. Doctors belong to regional associations, which negotiate contracts with the various sickness funds. Outpatient docs work in private practice, for the most part, with 60% in solo practices, 25% in dual practices, and the rest in group practices. Mid-level practitioners, like physician assistants, are also employed in most offices. About half of physicians in SHI programs are family docs, and about half are specialists. Patients can choose any primary care physician, specialist, or hospital that they like. There's no real gatekeeping mandate, meaning that people can go to see specialists without first getting the permission of their primary care doctor. Although some funds do offer them, and offer incentives for using those gatekeeping functions. A relatively small number of people do, though. Most docs work in a fee-for-service way based on negotiated rates. There are preset maximum numbers of patients per practice, as well as reimbursement points per patient. This means that there are limits on the number of patients and number of treatments for which a doc can be paid each year. If a doctor goes over, they may not be paid. About half of all hospital beds are in non-profit public hospitals. An additional third are in private non-profit accounts. The rest are for-profit, and that percentage has been growing. Most hospitals salary doctors who don't also work in the outpatient setting. The Federal Joint Committee decides what to cover and how to define quality. The Institute for Applied Quality Improvement and Research in Healthcare is responsible for quality assurance. Hospitals are mandated to report on 27 indicators so that they can be publicly compared. The country tries to control costs in a number of ways. There are a number of voluntary insurance schemes to do better disease management. Germany uses reference pricing with respect to drugs to try to get citizens to choose cheaper options. Basically, that means that the insurance will pay the amount of the cheapest drug in a class, and if patients want a more expensive one, they have to pay the difference themselves. A lot of research goes into deciding which drugs are most cost-effective. Finally, regional budgets are used to hold down spending. For instance, the doctor goes over what's expected for prescriptions for their patients, they are held financially liable. In 2011, Germany spent $4,495 per capita on healthcare, or about 11.3% of GDP. That puts it on par with France. It's expensive, except for the US, which is insane at $8,508 per capita and 17.7% of GDP. But unlike some other countries, Germans have great access. More than 3/4 of Germans are able to get same-day or next-day appointments with their doctor, putting them at or near the top of the developed world. Quality is generally good. Life expectancy at birth is 81 years, making them 24th in the world. That's behind Singapore at 84, Canada at 82.5, and France at 82.3, but ahead of the UK at 81 and the US at 79.8. In infant mortality, it beats most, if not all, of those countries. Germany has an above-average number of physicians and nurses. They have a below-average number of CT and MRI scanners. Their preventable mortality rates are well below OECD average. A 2012 study found that Germany outperforms the United States and sometimes the UK in preventing death. Loses to France though. Downsides? Because doctors are spread out so much, there can be gaps in knowledge about what patients have and what's been done. Surprisingly for Germans, it's somewhat inefficient. The fee-for-service model encourages more care, which some think goes too far. And some doctors hate the system, which can penalize them for doing too much. Germans worry that differences in physician salaries may lead to a primary care shortage in the future. Self-employed people also pay a lot for care since they're responsible both for the employer and employee contribution. Finally, some claim that systems that employ tiers of coverage, specifically the SHI and the PHI, often lead to the wealthy doing much better than the not wealthy. But it's worth noting that the vast majority of people choose the SHI option. What keeps the public and the private options so close in terms of quality, cost, and benefits? Likely it's the German government, and there's a lot to be said for it.
I'm here.
Okay, that's probably as good as it's gonna get. Thanks.
No more audio, right? There is.
Just stop it.
Do you have more audio or no?
No,
No.
I
Okay.
don't have another.
Okay, so we're gonna make this easy.
Because we are running out of time, I will skip slides and let's summarize here. So geography and oh, it doesn't work this way also. Yeah, I can use it.
Yeah?
Yeah, here you are.
Okay.
Geography and social demography. The Federal Republic of Germany is situated in Central Europe and covers an area of approximately 357,000 square kilometers. The country extends from north to the south. At its longest point, it's 640 kilometers, and it's great width. It shares borders with Denmark, Poland, Czech Republic, Austria, Switzerland, France, Luxembourg, Belgium, and the Netherlands. Germany had some 82 million inhabitants, 41 million of were women, and 400 million of whom were men. So, in other data, 78% women Germans, 11% Europeans, 7% Asians, 2 and 3% Middle Eastern, 3% 25% Turks, and 0.8 Africans, 0.5 Americans, and 1.7 unspecified. Most of the population is Christians, Christianity, almost 16%, 34% non-religious, 5.5% Islam, and 0.8 other religions. So its timeline, it's very actually here in German, the healthcare system is very rooted in history. So we can see it starts here in the 13th century, first hospital maintained by church, and in this point here, right. Should
Ilya, use this one.
yeah.
Use this
I see.
pointer here. Use this.
Oh, it's okay.
Top button. Okay.
Church is prohibited from provide medical treatment in 19th century, and we also know how church how we can get a treat in church hospital by cutting the veins and drawing the blood. So it finished here and there until this period. Imperial message birth here of the welfare state. So where we should speak about this person, Bismarck, because he created this whole system actually, and huge success of his model. We are talking about Imperial Message Foundation of Social Security System. It's here by this year, 1981, and the establishment of statutory health funds by Bismarck. Until this day, it's called SHF funds, statutory health funds. Establishment of the accident funds, pension funds, and in this year, about 11 of the total population is covered by more than 600 sickness funds. First, and this year, first comprehensive regulation between health funds and healthcare providers were established. So it's deeply rooted in the history, all this development that occurred in health care system of the German. In this year, the Persian medical fee schedule came into effect. From then on, coverage was continuously expanded with major parts of the population. Students and farmers included up until the 1960s and 1970s. And we should look at this period of time. I will show you why we are talking about this year. It's oil crisis, actually. Health pension and accident insurance became integrated in the Imperial Insurance Code. It's RVO, whatever, I can't pronounce this one. It happened in 1914. As of 1988, the RVO was transformed into the Code of Social Law, CGB, divided into 12 sections. The fifth section, SGB 5, covers social health insurance. The law in this 1957, the laws of statutory health insurance for pensioners came into effect. New laws also modernized the financial and management of hospital, 1972, Hospital Financing Law, KHG. 1974, self-employed farmers, artists, students, and disabled living in shelters, facilities received coverage from SHI. And we go back to this year, to this 1973. It's actually oil crisis and subsequent economic stagnation led to changes. It happens all over the world. Actually, in this year, the 1973 oil crisis began in October 73 when the members of the Organization of Arabic Petroleum Exporting Countries proclaimed an oil embargo, and it happens due to United States actually supported for Israel during the Yom Kippur War, and in Germany actually they started dealing with limits in 1970 and until 1980. It's almost 35 years of reforms. We'll see it later. It's due to rising healthcare costs led to ongoing discussion and reforms with the goal of cost containment, including income-oriented expenditure policy, reference price for pharmaceuticals, restriction on high-cost equipment and treatments, limits on the total number of physicians, co-payments, the Healthcare Reform Act GRG of 1988 and 1989 led to the SHI being the fifth of the 20 books in the Code of Social Law. So let's see how it works actually. What the history, and now we are talking about the Federal Ministry of Health, government structure. It's a pretty sophisticated scheme. So here we can see the BMG. The BMG actually is primarily regulatory and supervisory authority. It does not employ curative care doctors, nor does it own hospitals. This sphere of activities are health, prevention, and long-term care. So it's here. The role is supervisory, government institutions, statutory health insurance, social insurance, prevention, and we're talking about another department. Another department, it's under this supervisor, is State Ministry of Health. The Ministry of Health in the 16 federal states are primarily concerned with the provision of health care, especially hospital planning. They manage disease registration and are active in prevention and management of infection outbreaks. All states ministers are members of the Conference of Health Ministers, a forum for addressing technical and political issues. And we also have another one here. Federal Institution for Disease Control and Prevention, Federal Institution for Vaccine, SER and blood products, and Public Health Service. Okay. How the universities and the medical faculties in Germany and enroll students, universal and medical faculties work. 34 public medical universities, 2 private, and first year medical students in 2008, we can see the number here, almost 8,000, 9,000, excuse me, total number of medical students in Germany approximately high, 75,000 students, medical graduated in 2008, it's almost 9,000 degree types state examination. The study is 6 years. Restricted admission by grade point. Numerous classes, and we can see